Hello friends, I am back with another case. So this is one case like most of you have been waiting for and have been repeatedly requesting me. So this is a case of a total laparoscopic hysterectomy in a case of previous two cesareans. So you can see the picture, the entire momentum is adherent to the anterior abdominal wall and also at the site of previous cesarean scars. This kind of picture is becoming more and more common these days because of the rampant increase in the incidence of cesarean. So in these cases, the principle is actually simple. Always go from the normal area to the abdominal area. Don't try and tackle the adhesions first, because adhesions area, abdominal area is some place where you don't know what is the anatomy there. So go with the familiar aspects. On the left side, I have taken the ovarian ligament and the fallopian tube and kept it till the round ligament. I have not taken the round ligament. Right side, I am doing the same thing. You can see the ovarian ligament is on stretch now, and just adjacent to the ovarian ligament is a coronal vessels. So once I take this entire bunch from this side, the vascularity from that side will be compromised. So the uterus will be devascularized a bit. So stepwise devascularization is what I try first, and following the principle of normal to abnormal. So these all structures are normal. Adnexa is not affected. The coronal structures are not affected. So I'm taking whatever is normal first, tackling them, and then leaving what is abnormal to tackle later. Because if you try tackling the abnormal areas first, there will be unnecessary bleeding, the field will be dirty, and then even taking normal areas will be a big headache. So slowly I've taken all the coronal structures on the right side. The broad ligament has been opened. You can see the excessive vascularity there, pulsations happening there. So the right side coronal vascularity has been completely taken. Now I've put the uterus on stretch. There's a vaginal manipulator, the common one we use, the sound with valsalum. I've retroverted the uterus and put it on stretch, and I'm just trying to tackle the adhesions. It's basically more than bladder adhesions, an adhesion band which has formed between the uterus and the anterior abdominal wall. So I'm trying to cut millimeter by millimeter. That word is very important. Go millimeter by millimeter. Don't take this in chunk. You're trying to see, because with every single cut of yours, the adhesion band or the adhesion tissue gets everted because the uterus is on stretch. So if you can see that the adhesion tissue or the band is giving away. The hope is to find a good virgin plane by doing this, by going millimeter by millimeter, because bladder also comes and gets adherent to the same side. But at the look of it, we can see that there is no bladder there. I'm staying more close to the uterus, closer to the uterus to be cautious. If there is excessive bleeding, then you can understand that you have gone into the uterus, because that is where the vascularity is going to be. But if there is no bleeding, then you can be assured that either you are cutting on the adhesion band or at the junction of the adhesion band and the organ. Till now we have not faced much of a vascularity, so we are going in the right plane. I'm just cutting very millimeter by millimeter just to expose and evert the adhesion band. Behind this adhesion band lies a urinary bladder which we have not reached. Now back to the left side, I'm tackling the round ligament which I had left, in the hope of opening up the broad ligament and getting a space, trying to get below the urinary bladder, or at least to locate the uterine artery, because once you locate the uterine artery, things become more easy, as bladder always lies anterior to the uterine artery. Whatever complicated be the anatomy, this rule does not change. The bladder will always lie anterior to the uterine artery. But in these cases, it's tough to locate the uterine artery. So I'm exactly trying to do that. Left side I was not successful, so I've come to the right side. Broad ligament was opened earlier. These are all virgin planes. If you can see, the characteristic, the areolar tissue is maintained. So I'm again going millimeter by millimeter, the anterior fold of the broad ligament. So this is basically a combination of lateral dissection and central dissection to locate the bladder and to tackle the bladder. And during the entire process, the uterus is put on stretch, so that with every single cut of yours, a new plane will be exposed. So now if you can see, the adhesion band has gone down quite a bit. I am just releasing it slowly, trying to see if I can get a plane, a combination of blunt and sharp dissection. So centrally, I was not able to get much of a plane. So I again come to the left side, hoping that I'll get a plane here. So wherever required, if you don't need to cut, you can just use a harmonic scalpel for a blunt dissection. That's what I'm doing now. Just open up the jaws against pressure so that it opens up the tissue spaces. So even till now, we have not been able to locate or demarcate a clear space or clear virgin plane for dissection of the bladder. Still we are searching. So be very patient in such cases. Now I'm cutting more towards the uterosacral ligament. Be very patient in such cases. You'll have to go millimeter by millimeter. See the central plane, see the lateral plane, whatever opens up, you just have to pray and keep on trying. Any amount of haste, especially in this step, the worst disaster or the nightmare is going to be if you damage the uterine veins. Uterine artery is still okay because the bleeding will be pinpoint bleeding. They'll be spurting. You can locate the site and cauterize it. But if a uterine vein starts bleeding in this case, it's going to be disastrous because it will flow like anything. Not that it will cause a torrential hemorrhage, but it will cause complete dirtying of the field. After that, no anatomy is going to be visible. The entire field is going to be full of blood, soaked with blood, because the low pressure backflow which is going to come. So now from lateral side, again I've come to the central dissection, trying to find a plane from this angle, cutting millimeter by millimeter. Skills and more importantly patience is of utmost importance in such cases. A lot of people tend to give up in the middle, saying that they're not getting a plane or this thing, but mind you, even if you open up such cases, it's not going to be very easy. In laparoscopy, you get the lateral approach. That's the benefit and the better visualization. So now slowly we are opening up certain planes. If you can see, we are entering certain virgin planes now. The mark of a virgin plane is intact areolar tissue. So you can see that that plane vascularity is less. There is some virgin, there is some intact areolar tissue. So now I've got a better idea. So I'm cutting the tissue band. It's actually an extension of the broad ligament. Now I have kind of reached a plane which is sub or infra bladder region. So I've got a better understanding of the plane, or at least some plane is opening from the lateral side, left lateral side. Now we can make out the tissue difference, how the virgin plane looks different from the additions or the anatomically distorted plane. Now with that understanding, I'm trying to do the same thing on the right side, so that if I can get completely under the bladder, I can put the bladder on stretch and then just cut it from the central aspect. So as I've got a demarcation boundary on both lateral sides, I'm slightly more confident in cutting the central band and releasing it so as to reach the bladder. So if you can see, that is what I was exactly telling earlier. If you go too much into the uterus, there will be bleeding. These are the venous plexuses which are there in the uterine serosa. So once you reach that level, if you're too much into the uterus, what will happen is it will keep on continuously bleeding, oozing out. And how much you apply cautery or energy sources, it's not going to stop. It will keep on oozing. So that gives you an idea that you are too much into the uterus. So you can again stay a little away from the uterus so as to prevent that bleeding.
Good.
Okay, now things are more clear. If you can see, from left side I've got a plane where I am below the bladder. I'm trying to join it to the right side. See, now it's very clear. That is the cervix. You can see down the white part. I'm going anterior to the cervix. Bladder is above my instrument. I put the bladder on stretch, and with that understanding, I'm just trying to release the adhesion band. Now this is the adhesion band which is directly stuck to the previous cesarean scar. So as I always repeat in every video, whenever you cut any structure, always put it on traction, always put it on stretch. That keeps the vital structures away from your energy source. So now that's what I'm exactly doing. I have put the adhesion band along with the bladder on stretch, and I'm cutting it close to the uterus where I can feel the scar is, the previous scar is. Again, I put the bladder on stretch and I'm cutting at the junction of the tissue and the scar. Cut millimeter by millimeter slowly. At every stage, if you have any doubt, you can always revise the tissue margins, be confident, and then cut again. You don't have to hurry. So this understanding actually comes after a lot of years of experience. Because this, I don't know how much clear it is in the video, but when you do operate it, you'll get to understand what you're cutting and what you're putting on stretch. So that is a scar tissue area which has been completely released now. The bladder is not completely gone. Bladder fibers are still there. So now I am directly going into the, again, these are the superficial bladder fibers or the UV fold fibers which are still adherent to the previous year scar. As I said earlier, keep revising your margins, keep revising your tissue, see whether you are in the right plane. There is no hurry. Be sure and only then cut. It's better to be sure and cut rather than be sorry after cutting. So this was a case of previous 2 years with severe adhesions. You can see how the adhesions are and how it's panning out. I'm also taking help from above just to ensure that the uterus is on stretch. So left side I encountered some bleeding. I didn't want to go poking in the same plane, so I've come to the right side to see what can I see. From the right side now I've got a very good plane. That is what is called the virgin plane, and you can see areolar tissue. These are basically venous plexuses which are bleeding. That is more towards the uterosacral I am cutting now. And again trying to find a virgin plane. Once this is localized, I can cut the tissue band above it. So that is a fresh plane. So I've realized that this is a tissue band and I can just cut it off. So blunt and sharp dissection. It's a combination of blunt and sharp dissection always. I've again revised the tissue planes. So if you can see that yellow part, that is a part of the previous scar. That's how it appears. Previous scar always appears in that manner. I'm cutting more close to the uterus now, just to be sure. Ideally, you have to cut slightly below the scar tissue, but in this case, because anatomy is so distorted, I am cutting through the scar tissue and cutting very slow and millimeter by millimeter, because with every cut, a new plane will be exposed. Now that's very clear. What I am holding is actually the bladder. I'm putting it on stretch, the cervix is below, and I'm cutting as much as possible close to the uterus onto the scar tissue. So with every cut, you can see that the uterus is going cephalad and the bladder is moving away, caudally. So now a very thin tissue is left behind. You can see the white cervix, that is how a cervix appears. You cannot mistake that identity of the cervix. Now the last fragment of the bladder adhesion is left. With every cut, revise the tissue. Now it's very clear. The bladder is down. Cervix is visible. This is actually a tissue adhesion band, but because anatomy is distorted, there will be vascularity in that also. Plus uterine will be behind it because we have not separately tackled the uterine. You can also see that the bowel is so close. So be very careful while cauterizing or cutting. I've just asked the assistant to elevate the uterus, antivert it more so that I get some space between the bowel and the uterus. As expected, the uterine was there hiding behind it. So as soon as I cut it, there was a gush of bleeding, there was a spurting there. But it's okay, we have taken care of it. Now this is the cardinal ligament. Cardinal ligament and the collaterals of the uterine. Now right side it's very clear, more clear than the left side. You can see the junction between the cervix and the uterus where the uterine will be hiding. You can just cauterize it and then cut it with the harmonic scalpel. And with this, the entire adhesions are removed. Now we come to a basic normal hysterectomy because now the planes are clear. There's nothing. Now moving more to the uterosacral side. Uterine is taken in that bunch. We are taking the uterosacral cardinal ligament complex. Soon we'll be operating on the vault and opening it up. In such cases, whenever you have a doubt, it's always good to do the methylene blue test. So what we do is that post removal of the specimen and vault closure, we fill the bladder with saline, methylene blue diluted in saline, at least 250 ml, so that the bladder completely enlarges and we make sure that there are no micro leaks, because if there are any micro leaks or any doubt like that, there will be seepage of the methylene blue diluted saline into the peritoneal cavity. So watch for some time, let the bladder fill up completely, be sure that there is nothing, and then you can come out. So all these cases where you feel there is some bladder injury or possibility of any bladder injury, a micro leak or something, do the methylene blue test, and if required you can keep the catheter for 24 to 48 hours for better healing. Just revising the planes now, you can see the vaginal tube which has been inserted. It's popping up through the fornicial area. So I'm just revising the bladder and pushing it down properly. And then I'll open up the fornix. This is a straightforward simple step followed in all hysterectomies. Point to be noted is that just use one blade, the active blade of the harmonic scalpel. More than cutting, it's drawing. It's actually a drawing on the bulge which is due to the vaginal tube. So once the bulge is seen and you have cut and you have exposed the cervix, you can actually pull back the tube and just follow the borders of the cervix, putting the uterus on stretch. You can see the tube was withdrawn. So we have reached the stage that the assistant does not have to be told that this has to be done. We are auto-tuned to those steps. Left side uterosacral has been cut. Slowly right side uterosacral will be cut and the specimen will be out. This is the right side uterosacral cardinal complex. You can see the uterine artery cauterized end. We're almost nearing to the end of the steps. The specimen will be out soon. Yes. So the hysterectomy is complete. Now you can see the adhesions persisting on the anterior wall, where they have been, how they have been retracted, how the bladder has been tackled. The fallopian tubes are being removed in this case. Right fallopian tube. Both fallopian tubes have been delivered out. The uterus also will be delivered. It's not a very big size uterus, maximum a bulky uterus, will come out easily. Yeah, even without any more oscillation, the uterus has gone down. So only thing left is to close the vault. Closing with barbed suture 10, 15 centimeter. I prefer 15 centimeter. Barbed sutures are good because you don't need any assistant. There is no entanglement of the suture. The uniform tensile strength is maintained across the vault. There is no knotting involved. Make sure to include the peritoneum and the vaginal end, both. Otherwise, if you don't include either, if you miss out either of those, then that end can get inverted and there might be bleeding internally or externally. So make sure that you get the peritoneal end posteriorly, the both vaginal ends, and so that all microbleeders or oozers will be taken care of. Just cauterizing the right uterine end to be doubly sure. Now you have given a wash. So in these cases, always do the methylene blue test. I think we have done in this case, may not be demonstrated in the video. Yeah, it has been done actually. We are just do the methylene blue test, see if there is any micro leaks of methylene blue dye. If not, then you can be doubly sure that there is no injury to the bladder. Thank you.